Hello, future nurses. I know we've covered a lot of stuff over the last few weeks, so I wanted to very quickly go over Unit 3. My goal with these is always to do this in less than an hour. Sometimes I can. So one of the things we talk about are QSEN. Those are that qualities, safety competencies that nursing students should have. There are a few related to mental health. Our care should be patient-centered, making sure it focuses around the patient, using the most up-to-date data, safety, minimizing risk of harm to our patients. Informatics, technology, teamwork. We are going to work within an interprofessional team, open communication, mutual respect. And then again, evidence-based practice should always be what we're using. The ANA standards of care, the nursing process, this is something you've seen before. This is how, as nurses, we kind of do things. We start with assessing, we end with evaluation. When we're assessing, specifically in psychiatry, we are assessing this data. We're looking at what the patient's doing. We are looking at the cultural, the social factors that influence health. Our primary source of data is the patient, and kind of like we talked about before, we do have to look out for those language barriers, use that hospital-improved interpreter. Secondary sources of information, family, friends, neighbors, police, medical records. We often have patients in mental health who are brought in, especially in our area where you're going to clinical, through the legal system on that notification of emergency detainment, and the police are kind of providing you that background information. The family might be able to tell you like, hey, look, the patient's been deteriorating, or they have a history of X, Y, and Z. So that secondary source could be really good for gathering a bunch of data. We do have some age considerations. Children, we have to get parents involved, and we have to see what's going on. We have to look at their developmental level. We can interview through play, observation. Sometimes just watching a kid is a really good way. Adolescence tends to focus on confidentiality. They don't want you to tell their parents. However, we do have to let them know suicide, homicide, sexual abuse, anything that puts them at risk. We are going to have to tell. We can't keep that a secret. Older adults, we have to consider age-related changes. On that last slide, it talked about the HEADS assessment. This is a way just to kind of focus your adolescent assessment. Some different areas we would want to check out. What sports, what after school activities, do you have a job? Suicide, sexuality, both are you sexually active and are you part of a gender or sexual minority? So the whole purpose of that psych assessment is, one, we want to establish that rapport. We want to have a way for our patient to talk to us. The chief complaint is always why, which I know we don't say why as therapeutic communication, but why are you here? What brought you to the clinic? What brought you to our facility today? We generally want to do the chief complaint in the patient's own words. We always still, though our mental health, have to do that physical status, the baseline vitals. Risk factors, are they that older white male who has access to a weapon? Our mental status exam we're going to talk about, that is the psychiatric head to toe. Psychosocial legal problems, problems with family, problems with housing. Identify goals and get that what is going to be our plan of care. So again, this kind of goes through that in the kind of a same different way. Review of systems, any constipation, do you have any headaches, any issues with X, Y, and Z? Lab values can be important because hypothyroidism may look like depression. Hyperthyroidism may look like anxiety or mania. We often see abnormal liver enzymes. If a patient has raised ammonia, they can almost look psychotic in some ways. Tox screens, what drugs are they using? The mental stats exam is what we're going to go through more and more, and that is our head to toe in nursing. Let's see, spiritual religious assessment, more so we've talked about cultural, a lot of it. We talked about that a lot more so last unit. We want to make sure that we validate the assessment, make sure we're using something reliable. Do we have old medical records? Do we have information? Can we trust our patient? Are they psychotic and we just can't get data on them? Sometimes you see it phrased as a poor historian. The patient doesn't quite know what's going on. And then rating scales, PHQ-9, COW, CWA, there's a whole bunch of different ones we can use that are good to give us those objective numbers for how our patient's doing. So what do we see in that mental status exam? Affect and mood. And mood is one of the simplest. Are you happy? Are you sad? What are you feeling? Have you been full of energy? What's going on? Affect is what we see on their face. Thought process is how their thoughts are moving. Do we see flight of ideas? Do we see circumstantial speech? Memory kind of speaks for itself, short and long term. Do they know what they did this morning? And do they remember what happened 5 years ago? Cognitive ability, just the ability to process information. Do they have concrete thinking? Concrete thinking would be if I were to say, do you have ants in your pants? To a kid who's jumping around, they would freak out because they think they actually have ants in their pants. They can't separate into that as an expression. Physical behavior, are they running around? Are they sitting? Are they responding to internal stimuli? Right? So responding to internal stimuli is that kind of we can see you hallucinating. Speech patterns, are they repeating things back? Are they only talking in rhymes? Are they making up their own words? Psychosis, we tend to see auditory visual hallucinations, but we can see gustatory, olfactory, tactile. Perceptions, what kind of do they recognize going on in the world around them? What do they look like? We haven't really talked about it yet, but we will see people who are maybe flamboyantly wearing too much makeup, or they're in very heavy winter clothes in Texas in the summer. Nonverbal, are they looking at the floor, refusing to make eye contact, pulling away? Insight, are they able to realize that they have a problem? Judgment, can they make good decisions related to their health care? I'm going to skip through this just because we don't have time. Best pick is just an acronym that we can use to kind of formulate all those different what we see in that mental status exam. A sad person scale is a specific scale that we can use for suicide. If they're between 50 and 29 or over 58, we give them a point. The more points, the higher the risk for suicide. The Montreal Cognitive Assessment, again, is just a different assessment we can use in some of our elderly patients to look at their cognition. When we do our nursing diagnosis, we have those 3 components. It's just like every other nursing diagnosis you've done, except one we like risk for. Well, in med surg, they're going to tell you don't do a risk for diagnosis. If you have a suicidal patient and you don't do risk for suicide, we in psych are not going to like that because that is their problem. It is not, in that sense, a potential problem. We have 3 types of diagnosis: problem-focused, what is going on; health promotion, we want the patient to be motivated to get better; and that risk for, something's preventable. So risk for suicide would be our big one for mental health. Our outcomes, our goals are going to be written in positive terms, what we hope the patient will accomplish during their stay. When we are looking at our interventions, safety will always be first. Across the board, I know y'all were even talking about this yesterday in lecture, right? Suicide. I don't necessarily care if my patient's not eating, if they're going to kill themselves. So we have to go through that. Our goals have to be individualized to each patient because we're going to do different things. It will have to work with what we're going, evidence-based practice. Does it follow QSIN? All sorts of different things. And when you've been doing this in mental health for a while, you kind of learn. My patient's suicidal. I'm going to do this, 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 and this. And there's a few different things. I'm going to sign a no harm contract. I'm going to increase to a 1-to-1. I'm going to search to take away sharp objects from their room. Make sure that they don't have any contraband. When we're implementing, it could be across a wide variety. Coordinating care, health teaching, milieu therapy. How are they interacting on the unit? Pharmacological, integrative therapies, medications. Advanced practice has some of their own interventions. They do psychotherapy, prescriptive authority. They're the one who's telling you, hey, our patient's anxious. Let's go ahead and give them that benzo. And it just goes over a lot of what we talked about before in a different format. I'm going to skip this. When we're evaluating, they need to be ongoing. If something changes, we need to look at that goal and be like, is this goal, our intervention still applicable for this patient? Because if they're not, we need to change. We should have criteria. If I'm going to do ineffective coping as my nursing diagnosis for my patient, and I have a goal like my patient will cope better. That is not, there's no criteria. There's no way to judge my patient's coping better. So that's where those SMART goals come in. Document has to accurately reflect the patient's condition, regardless of the way, including if they're not adherent. Patient refused medications. How are they going? Two types of documentation. We generally do narrative notes, at least where I have been in mental health. Common language. The format varies. You can forget something. Very easy to do that subjective. And you'll kind of see this in clinical. If you have a patient in psychosis and you ask them a question and they're like, they give you a random answer and you're like, that's not an answer to my question. It's really easy to put those quotes into a narrative note. Problem-based is that SOAP note. It's structured. We get rid of the unnecessary information. However, it's time-consuming and it's often problem-focused to one thing. We do a lot of like flow chart even when we paper chart in mental health, where if you have a patient who's in restraints, you won't have either of these. You will have like a packet and it will have everything you need. And as long as you answer it, you're good. So documentation is crucial. We have to go through it, including that documentation of non-adherence, right? Subjective information goes in quotations, especially in mental health, you'll see. When we document that non-adherence, we're not necessarily going to say they're non-compliant. We're just going to say the patient refused medications. We don't use the word non-compliant. We don't document early. You have to document as things are going. We're not documenting our opinion. And opinions get tricky because you might be like, well, my patient's anxious. But if they didn't tell you that they're anxious, we cannot document that they're anxious. I can document that they're pacing, that they're crying, that they're wringing their hands. All of those things that I see. If the patient were to come up and tell me I am really anxious, that is where I'm going to use those quotations because that is the patient's own words. It's their subjective information. And then I would document it. But I can't document my opinion. We're going to document a bunch of stuff. Their condition, medications, treatment, tests, what's going on. It's going to kind of depend throughout the day. Therapeutic communication, the clinical interview. We have a communication process. This is pretty much a review from when you took nursing 3180. So these are things you should know. We do have factors affecting communication. Is your patient psychotic? Do they have mania? Are they depressed? Is there a language barrier, cultural difference? Environmental factors on psych units, it's loud. There's no privacy. It's uncomfortable. In relationships, we tend to see this symmetry or asymmetry. They call it complementary. In our friendship, if we're just talking with our friends, it is symmetrical. There's an even balance of power. When we're talking with patients, we often have the status and power above the patient. There's an inequality. As the patient recovers, as they get better, it becomes a little bit more symmetrical. Verbal and nonverbal communication. Verbal, it's everything the patient says. They communicate their beliefs, their perceptions. It talks about interests, their judgment. Sometimes it could be clear, or we can have conflicting messages. Your patient's telling you that they're happy, but they're sobbing. Nonverbal communication makes up 70-80% of communication. Tone of voice, the emphasis on words, their physical appearance, their facial expression. How are they sitting? Hand gestures. We do have some tools for communication, and on the next few slides, we'll go over these. Silence. Silence, especially for a new nurse or someone who's not used to it, it can be uncomfortable. However, it provides that moment of reflection. We have to realize that some of these psychiatric disorders slow down thought process. And even not just these psychiatric disorders, if you are working at a neuro unit and we have someone with a TBI or with a stroke, it can slow it down. Our patient should be the one to break that silence. Active listening, giving your patient their undivided attention, going through it, paying attention, sounding board, interacting, having that conversation, not charting, not being on the phone. not trying to get meds ready while talking to the patient. We do have to take cultural considerations into play. We talked a lot about communication across different cultures last quarter. Can we communicate even within the same language? Eye contact. Do we have a client of a culture where they just don't want to maintain eye contact? It's just not within their culture. So if a patient's not always making eye contact with us, we should not force them to. It does not show service. It doesn't do any good. Touch of privacy. We tend to think therapeutic touch is really good. In mental health, we tend to shy away from touch unless we're certain of it. And then we always have to look at those cultural filters, those bias that is going on, what we pay attention to, what we ignore. We may, just because of our patient's culture, kind of paint them into a light. And then once we start talking to them, we were completely wrong. We made those judgments up front. Clarifying techniques are we have a whole bunch, and they're going to be on the next page. And there are a bunch of different ways to be like, I don't know if I understand you. How can I understand you better? Would you explain this in more detail? Can you tell me more about it? Can you describe this? Can you give me an example? We're getting feedback on if we're understanding the patient's message. So when we look at different clarifying techniques, paraphrasing, I'm not sure I understand you. You seem to be saying. We're kind of restating the basic content back to make sure we're getting it. Which I know I just said restating and paraphrasing, but in restating, we're going to use key words that the patient is speaking. I heard you say you were really upset when you got into a fight with your mother. And we're going to pretty much reuse their entire statement. Reflecting, we're going to take a simple statement that helps convey. I see you picking at your cuticles. Are you anxious about something? And we're trying to look and connect their actions to the emotions and what we're hearing to make sure we understand it correctly. Exploring is a wonderful one. It helps us look at those important ideas, experiences, relationships. You brought up this. Can we go in and talk about this topic in more detail? And that's a lot of that, tell me more. Can you describe where they maybe hit on the topic briefly, but we're like, you brought up this fight that you had with your husband. Can you tell me more about how you were feeling during that fight? Open-ended and closed-ended questions. Open-ended is anything where there's not a yes or no answer. There's not a specific answer. Let's talk more about your relationship with your mother. Can you tell me more about what your childhood was like? Close-ended questions on a scale of 1 to 10, what's your pain? Have you ever done heroin? That's generally a yes or no. Projective questions are what if? And it helps the patients look at their situations differently. Well, what if you and your husband would not have gotten into a fight? The miracle question is kind of just what it sounds like. If a miracle were to happen while you were sleeping tonight, when you wake up in the morning, how will your life be different if that miracle came true? We can use that one to identify goals that maybe the patient would be wanting to pursue. It's a very basic question, but it does garner a good conversation if your patient's not always looking towards the future. We do have non-therapeutic techniques, and sometimes these non-therapeutic techniques, being able to identify and realize what they are almost more important because you catch yourself using them. Excessive questioning is multiple questions, especially close-ended, consecutively, rapidly. It can make you seem like an interrogator. Now, I will always say there's a time or place for excessive questioning, like during an intake. You have a patient and they're so frustrated, you just want to get them into the unit, get them to bed, give them meds, and we can't do that until the intake is done. If I ever had to do that, I would always apologize. I am so sorry. I have so many questions. If you need a break, if we need to slow down, just let me know. But if I don't get through these questions, we cannot give you those medications because until they're admitted, we can't give meds. Approval, disapproval, it's not our place. We don't give praise. It just gets very complex. We do not give advice. When we give advice to a patient, we're interfering with the patient's ability to make personal decisions. We can help guide them. We can provide them with information. but they need to make the decision themselves. Why demands an explanation of wrongdoing? Well, why did you do that? So we never want to use why. Minimizing or disregarding feelings. If your patient tells you that they're sad and they're hopeless because their pet goldfish died, and you're like, "Oh my God, it's just a goldfish." Well, maybe that goldfish was super important to them. Maybe that goldfish has a different meaning. So we do have to take whatever the patient says and understand that it's all different. Another one that's not on here is disagreeing. We don't always want to fight with the patient. You'll see this sometimes when we get into psychosis. If the patient's like, there are spiders crawling the walls, you don't want to be like, there are no spiders, you're hallucinating. We kind of have to have that good conversation. Helpful guidelines, speak briefly. If you don't know what to say, don't say anything. Focus on the patient's feelings. That old cliche, how does that make you feel, is honestly not wrong. Don't give advice. Don't rely on questions. Watch the nonverbal cues. You can see sometimes if you say something and it didn't go over quite so well with the patient, they pull away. And the focus will always be on the patient. Telehealth, video conferencing information, confidentiality has all complicated everything. It's great. We can do live interaction. We do group therapy during telehealth. If there's no providers in your area, you're now open to more. But we do have to watch out for that safety, who is else in the room, making sure it's a secure environment when we are doing it. When we're preparing for the interview, the patient sets the pace. We want the setting to be the most comfortable. Seating, we want to try to be at the same height. You want to avoid a face-to-face arrangement. We want to consider safety and comfort. And so we don't always want to position the patient between us and the door, but we don't also want to position ourselves in a way so that the patient feels trapped in the room. So we want to make sure we both have easy access to the door. Introductions, we bring up confidentiality. We ask how the patient wants to be called. And then we tend to use an open-ended question. Where should we start? Tell me more about what's been going on. Some more tactics to avoid arguing, minimizing, challenging, false reassurance. Everything's going to be okay. We don't know that everything's going to be okay. We don't want to try to speculate on what the patient's saying. So that's where a lot of those clarification techniques come in. I hear you saying this. When you say that, do you mean? If a patient shies away from an area and they don't necessarily want to discuss it, we shouldn't necessarily dive in and try to talk about it in that moment. We don't ever want to sell the patient on accepting treatment. If the patient refuses meds, they just refuse meds. It is what it is. We shouldn't have that dialogue to be like, well, this is why you should do it. Patients oftentimes will criticize others, especially staff. And even if you don't like night shift and the patient's criticizing night shift, we don't want to dive in on it. And that kind of covers the last two. Attending behaviors, eye contact, body language. Look at our proxemics. I can never say that word. How close are we sitting to the patient? Intimate distance is considered within 18 inches. An intimate distance is great for your spouse, for your children, family members, really close friends, but not appropriate for patients, right? That touch is an invasion of privacy. We don't want to get too close. We want to try to stay that personal distance, maybe even social distance. If our patient's being dangerous, I always say 2 arms length away so that the patient, you have more room. The patient can't quickly grab you, hit you, punch you, kick you. Our voice quality, are we anxious and our voice is coming in? Are we super tired? Just kind of how we're looking at with the patient. Process recording you'll do in clinical. Things that promote growth, genuineness, letting the patient know that you really do care about them. Positive regard, right? Paying attention to them, not passing judgment on their values. If your patient was like, oh, hey, I've been using cocaine and sleeping with hookers, we're not going to be like, why would you be doing that? That's horrible. We have to realize that there's more going on. We want to help them develop resources, point them where they can go find things, but we don't always want to tell them the answers. I'm going to skip through these questions. And then we're going to go into the therapeutic relationship. So we have to realize there's two types of relationships. We have social relationships. Mutual needs are met, friendships, right? We give advice. Sometimes there's superficial communication. But then we have those patient-centered, and this is where a lot of our communication skills are aimed at helping our patient grow. Peplau's theory of interpersonal relationships, we've seen this before. It's the foundation. She was that first theorist to say what the nurse-patient relationship is. It focuses on not on what we do to the patient, but what we do with the patient. Illness is a way for our patients to grow. So what, as a nurse, is our goal, is our function in that nurse-patient relationship? We want to get the patients to talk about distressing thoughts and feelings. We want to help them problem solve, help them with their ADLs. What are their self-defeating behaviors? Do they have a maladaptive coping skill? And are we going to help teach them an adaptive coping skill? Self-care and independence. We want them to shower. We want them to get dressed and comb their hair and shave, whatever they feel good about. We have to talk about meds. We have to talk about their symptoms. That's a big one. Promote recovery. Recovery, we could have a whole separate lecture on just what is recovery. And recovery is going to be individualized to each patient. What is your patient's goal of better? Model and respect boundaries. And we'll go into boundaries a little bit more. We have to have those appropriate relationships with our patients. And we want to make sure we're showing and setting the example. So when we continue with Peplau, we have skills. We have patients who have suffering. They want to improve their quality of life. So we help with that. And that helps both the nurse and the patient move forward. These kind of go into those stages of the nurse-patient relationship, which we've talked about before. Orientation phase, we set the boundaries. We look at what we're working on. What are the needs? In the working phase, we encourage problem solving. We help develop new coping skills. And as we move from working determination, we support change. So what is a boundary? Boundaries exist to protect patients. These are expected. You have to have them. There are tons of different boundaries, right? Physical boundaries, we're behind a nurse's station. Social, we can leave. Psychological, we have that sense of power. We do have something called transference and countertransference. And transference and countertransference comes into that blurring. Transference is when the patient unconsciously places feelings onto the nurse from someone from their past. So maybe the nurse reminds the patient of their mother. And oh my gosh, my mom was so sweet. I just love my mom. And they're super nice to the nurse. And they're trying to really get up into those personal space. Or maybe the patient hates the nurse and no one can figure out why. But the patient unconsciously is like, that nurse reminds me of my ex-wife. And these are very Freudian terms. Countertransference, we as the nurse are taking feelings related to people into our past and putting them into the patient. Maybe we're over-identifying with the patient. That's common in countertransference. I had similar trauma when I was a kid, and I'm the best nurse for this patient. I know what they're going through. Or maybe the patient reminds them of their sister, and they hated their sister when they were younger. So it could also go both ways. Transference is patient to nurse. Countertransference is nurse to patient. Social relationships also blur boundaries. We do not want that. And remember, our patient's needs are always the one we're focused on getting met. So the phases of Peplau's model, we'll go through each of these, what we see in them. Pre-orientation is a lot of before the patient comes, before we clock in for our shift, when we get that assignment. Hey, you're going to be working on this unit and you have these 10 patients, and I get report. Or you're already at work. Hey, you have this new admit coming. It's a 35-year-old male brought in on an NED, where we're kind of figuring out what's going on. The orientation phase is when we meet our patient. Hey, my name's Julie. I'm going to be your nurse today. How are you doing? What do you like to be called? This is what's going to be happening. That kind of like when we talked about with the adolescents. I'm not going to tell anyone what you tell me unless it's one of those safety concerns. The working phase is that meat and potatoes. We're focusing on problem solving. We're working on achieving goals. We're exploring um, areas that cause problems with our patient. We're reassessing. We're teaching. We're providing that education. It is that big meat and potato of the relationship. The termination phase is discharge. The patient leaves. We don't see them again. We talk about how they achieve their goals or what they need to work on. We do not set new goals. We give that discharge instructions. And a lot of times it's like, it's call 911 if you're feeling unsafe. Here's the suicide hotline number. Making sure they have their referrals, any outpatient care we're setting them up with. Values and beliefs. Values are either what we find important. I always, and I think just because I did this lecture once during Christmas, think of Scrooge versus Bob Cratchit. Scrooge very much valued money. Bob Cratchit valued family. And we see those differences. Belief is just kind of what we believe in. What are we trusting? What do we have faith in? It very well could be religious. It could be an opinion. It could be anything. We do have to know ourselves. Look at our culture, subculture. What are our beliefs? What does our culture say? Because that will affect how you treat your patients. What helps our patient grow? We've kind of talked about this a little bit. Genuineness, being open and honest. Empathy, we're not always going to know what our patient went through. We can't always put ourselves in their shoes, but we can try to understand. And then regardless of who your patient is, the CEO of a company or a individual who's homeless and has a substance abuse problem and is prostituting themselves out, we should be treating them the same. Things that hinder or help the nurse-patient relationship, the pacing of that conversation. How are we listening? That initial impression, not just of us on the patient, but also the patient on us. Do we walk in and we're nice and cold, we ignore them, we're fiddle-faddling around the room before we start talking to them? Or do we come in as we're nice and warm? Do we show them that we care about them? That they are more than just a patient? We want the patient to have comfort in balancing, and then honestly, patient factors. We don't always know what's going on, but a lot of times our patient, I'm trying to think of the right words, their communication or their lack of communication or their diagnoses, that can come into play and affect the different relationships with the patients.
The last thing we have from this section is therapeutic groups. And there's a lot of overlap in therapeutic groups with therapeutic communication, so I think this is actually pretty simple. When we look at groups, we have some concepts that are common to all groups. Therapeutic factors, they're curative. They are crucial for helping our patients achieve change. AA is a huge one. I mean, we refer so many patients because it has just proven as a group to be helpful. Group content and process, what's happening? What do we hear in the discussion? And what's all that kind of underneath stuff that's going on? We do have some different factors in group therapy. Interpersonal learning, patients gain insight into themselves based on their feedback from others during the group. Catharsis, we express feelings, that therapeutic discharge of emotions. Installation of hope. I generally, as the leader, we kind of make our patients feel more optimistic as they're talking about their progress, as we're talking about successes. Universality. Patients recognize that they're not the only one who feels this way. They're not the only one who's had this experience. Other people have too. And especially when we kind of pair that with that installation of hope, everyone, it's just this, I can do it. If you've gotten through it, then I can get through it too. Imparting of information, just sharing, getting stuff, learning, teaching, maybe by the group member, maybe by others. Altruism is helping someone. How do we when we say helping someone, it's so the 12th step of AA is, hey, you know what? I have done all of this. Now am I going to go and kind of spread this message? I'm going to help other people who need it. And that's kind of a really big altruism. I'm going to find other people. I'm going to work as a sponsor. It could also be, hey, you're new to the group. Welcome. Oh, you need to go to the bathroom? Let me show you where the bathroom is. It could be tiny things. And what altruism is when we're helping someone, we're making ourselves feel better and we're making themselves feel better. The patient feel better. Okay, I'm going to try to say this one correctly. Corrective recapitulation of primary family group. Sometimes in a group, we see behaviors that come out and it's like, do you talk to your wife like that? And we can kind of see some of these things and it's like, you say you're struggling with your family, but if you're acting like this, I kind of get it. Development of socializing skills. A lot of our patients in mental health struggle with socialization. Group cohesiveness, that kind of feeling of belonging, and existential resolution. We're solving our problems. This kind of goes over it, what all of them are. So we have some phases of group development that we are going to talk about. There's 4. They're very similar to the nurse-patient relationship. In the planning phase, we're going to talk about what we're going to name the group. What is the group going to accomplish? I'm going to create Miss Julie's coping skills group for nursing students. I got a name. What am I going to do? I'm going to teach nursing students coping skills. Type of patients. Who fits the criteria for this group? And we have a few different ways we can look at that. Talking from your next slide, we have what's called a heterogeneous group, where there's just a bunch of differences. We could have a homogeneous group. We have a central trait. So our group may be kind of homogeneous in that everyone who attends my group, you have to be a nursing student with Galen. We could take it super specific. I am going to do a breast cancer support group for young women in their 20s who've had a diagnosis of breast cancer. We're now kind of specifying a diagnosis, an age, a gender. Or I could just do, I want to do a breast cancer support group. Anyone who's had breast cancer, male, female, 20 to 99, come on in. So it could kind of vary. Group schedule, when are we going to meet? Physical setting, we're going to get a classroom at Galen. What are my responsibilities? Well, since I'm teaching coping skills in this group, I'm going to come prepared to talk about different types of coping skills each week. But then the members also need to be prepared to talk about how they're utilizing their coping skills and what they are finding works for them. And then how are we going to evaluate our patients are getting better? We talked about the heterogeneous, homogeneous, closed group, restricted membership. Our group may be a closed group, our Galen Nursing Coping Skill group, because we're going to start and we're going to have that first meeting, and whoever shows up to the first meeting, that's the only people who can come. Or we could have what's called an open group, and we tend to see like AA as an open group. Anyone can show up to any AA meeting anywhere across the country. You could be traveling and just pop in and join the group. So members are constantly being added. We could have a subgroup. In my coping skills group, maybe we have one for parents with young kids. And we have our coping skills group, but then, one day every few weeks, those same group, the ones who have kids will meet. And they'll kind of talk about how they're utilizing their coping skills around their kids. Theoretical foundations for group, these are really similar to when we just talked about theories. Humanism is very much patient-centered. It's an existential experience, self-actualization, very much like the leader's not directive within the group. Cognitive behavior is specific, and this goes to that cognitive behavioral therapy. We're going to look at specific maladaptive behaviors and thought problems. A lot of goal setting, planning, modeling. Psychodynamic, a lot more listening, confronting, probing. I heard you say this. Can you go more into it? Where the group leader kind of just lets everyone talk. And we just kind of ask those clarifying. Let's dive more into this. Can you tell me more about this? Psychoeducational is very much focused on the healthcare provider in the sense that we are coming and we are teaching. I'm going to go and I'm going to do a group on sleep hygiene. Let's go and talk about sleep. Systems group is quite involved. You won't necessarily see this. It's very much on social equality. So we have some roles that our group participants might take. Task roles are going to help keep the group focused. We are here to talk about coping skills. Let's talk about coping skills. Maintenance roles are going to be the ones that are keeping the group cohesion. Checking in, oh my gosh, you had a birthday. How are you? How are your kids? Like making sure everyone feels like a family. Individual roles have nothing to do with the group. They're solely focused on a personal agenda. And when we look at that individual roles, we have a few. We have the aggressor. They're just aggressive. They come out, they talk, they're just not right. They're starting fights. It's just difficult to work with. The blocker is more so going to block the conversation. They're not going to follow in. They're not going to want to talk about it. The dominator, it's all going to be about them. Everything in this conversation is going to be about them, and it's constantly going to come into them. Help seeker, y'all have to help me with this problem. Well, we're here to talk about coping skills. You're bringing in this total separate problem of I need help with study skills. Great, let's form a study skills group then, because that doesn't end. And the special interest pleader kind of comes in the same way. Trust me, y'all, you will not get these confused. So nurses group leaders, what do? We focus more on the psychoeducational groups. We're going to talk about meds. We're going to talk about health. I've done groups on like, hey, this is how your meds work. I've done groups on, hey, let's talk about communicable diseases. Dual diagnosis. Hey, you're here in an addiction program. Let's talk about substances of abuse. Symptom management. Hey, we all have, headaches. Let's talk about how to manage headaches and constipation. Stress management. Let's talk about our coping skills. Community meetings. Sometimes you see these run by the techs. We are all here on this unit. We have rules on the unit. How does it all go? Self-help and support groups. Though they put this here as nurses as the group leaders, you won't always see a nurse as a leader of a support or a self-help group. Because to be in that support or self-help group, you generally have to have the problem. So if we have a nurse who has breast cancer, she very well can help lead a self-help support group for breast cancer. I've never had breast cancer. I should not be the one leading a support group for individuals with breast cancer. We do have some styles of leadership. Autocratic, we're going to exert control. We see autocratic leaders more so inpatient because the patient population is always changing. A democratic leader, we want the group to talk. We want them to problem solve together. And it's more so a true group. Laissez-faire might be like your art therapy type group. Hey, this is what we're doing. I'm not really going to try to force the direction. We are doing art. Everyone do your own art today. We have some communication techniques for the group leader. A lot of these are kind of the same as what we saw in our individual therapeutic communication. Active listening, right? Making eye contact, paying attention, asking those important questions, giving information, clarification. When you said this, what do you mean? Confrontation is a little different. You're saying one thing, but your body language is telling me something else. Empathizing, recognizing someone's feelings. Reflection, I noticed you clenching your fists. What are you feeling right now? It sounds like you were really upset when that happened. Summarizing, today we talked about X, Y, and Z. And then just providing support. So purpose of group leaders intervention. Sometimes we have to intervene. We may want the group to go and kind of be more democratic. We're kind of there just guiding, but we need that group leader for that atmosphere of safety and trust. We have that aggressive, right? What if someone gets upset and they start throwing chairs? Well, we may have to clear the group room. Hey, can everyone else step outside, right? Focus on safety. Maybe we can stop the abuse or hostility. I appreciate your comment, but we are not going to talk about that today. We can enforce rules. One of the rules we see a lot is like cross-talking. If someone else is talking, you should not be having any other conversation. If patients start getting off topic and next thing you know, they're talking about something, I don't know, random, then we'd shift back to whatever the group is about. Provide feedback on their actions, on their behaviors, to draw connections. Jim, I heard you say that you were really sad and that when that happened, and that sounds a lot like what Mary said. Mary felt really sad when this happened. And we can kind of point out that connections. We can offer support. We can encourage risk-taking. One thing you sometimes see, depending on the type of group, is especially those community groups, it turns into just an unproductive gripe session. And everyone's just complaining. Where we come back and we just focus. It's very helpful if we have a co-leader.
someone else, one allows for that person to be changed. It allows for us to kind of debrief after. How do you think it went? But then also it allows the patients to see us communicating with each other. Co-leaders can also come in handy with that like aggressive group member. If someone does become physically aggressive where we're concerned about safety, because then your co-leader can take everyone else out of the room and we can stay there to try to de-escalate the person who is just not being safe. Ethical issues, we have to have informed consent. We don't want people talking about what's going on outside a group. If you go to an AA meeting and next thing you know, you're at HEB and you're like, oh, hey, I recognize that person from AA. We shouldn't be calling them out on that. There generally will be rules about leaving, how you can socialize outside the group. Do we have to force someone to leave? Are they that disruptive or that not safe? Training or credentialing. As an RN, we can only do certain types of groups. I cannot go do a CBT group as an RN. So we have to make sure we have the ability to do it. The American Nurses Association lists out what is the scope and practice related to group therapy. And we should be using just evidence-based practice techniques. So we talked about an aggressive group member, briefly kind of what we would do with someone who's aggressive, but what would we do with that monopolizing, demoralizing, or silent? So the monopolizing group member is someone it's all about them. They're talking, they're going to constantly go. We need to remind the group that everyone should have an equal opportunity to participate. We need to address the behavior with specific individual limits. So I appreciate you sharing today, but everyone is going to need to talk. Can you limit your comments to 2 or 3 per session? And we actually tell them you can't talk, or you can only talk this many times. The demoralizing group member is a little hard. They're putting other people down. And we have to listen to their comments objectively. They're probably coming from somewhere, but we need to respond matter-of-factly, and then we want to address them individually. If we have a co-leader, this one's helpful because we can like pull this demoralizing member aside, maybe after group, or even pull them out of group, which pulling out of group gets tricky. It'll depend on the situation, but we have to just address them one-on-one. Well, the monopolizing member, I will call you out in group. You can only share 2 to 3 times. The demoralizing, I would address individually. A silent group member may not be sharing for a wide variety of reasons. They're anxious, they're scared, their thought process is slow. So for this individual, we want to give them a little bit more time. We want to wait for them to respond. Some things that we can do is hand out paper and pencils. I want everyone to write down a time when they felt scared. I'm going to give you 5 minutes, and it gives that person a chance to kind of slowly process. And then they're kind of can prep themselves and be prepared when it comes time to share. So we're not just putting them on the spot. Expected outcomes is going to depend on the reason we have group. If we're talking more about therapy group, we want behavior changes. We want their symptoms to change. We want them to have insight into why they are doing things. They use medication group, but it could be any type of education group. A medication group, we'd want them to have an understanding of their medications. If we were talking about a education group on sleep hygiene, and sleep hygiene is just super easy, my expected outcomes would be my patients would have a better understanding of the sleep cycle, a better understanding of strategies that they can do to promote sleep, of strategies that they are doing that are hindering their sleep. Patients will report a increase in amount of time that they are sleeping within the next month. So we can kind of specify that a little different, and that takes us to the end, y'all. I did that super fast, but we kind of went through everything. If you have any questions, please let me know.